For our project, we decided to look at the mental health effects of prescription drug addiction. Together, me, Spencer Waterbury, Jace Hanna, Mackenzie Kramer, and Dakota Feldman will walk you through this issue. There are three main kinds of prescription drugs out on the market: opioids, anti-anxiety medications, and sedatives, and stimulants. These drugs cause a variety of symptoms, but there are a couple effects that they share in common. They are engaging in risky behaviors because of poor judgment, using other illegal and recreational drugs, being involved in crime, motor vehicle accidents, decreased academic and work performance, troubled relationships, and other health problems. While these effects may be very harmful in the short term, the long-term outcomes that they lead to can be even more devastating. The long-term outcomes of using prescription drugs are very severe. They can range from stealing and foraging for more prescriptions to appearing to be high, obviously, to death. In the long term, a cycle of poverty emerges. As they make any money, they spend it on drugs because it alters the chemistry of the brain to demand more of it. After that, they then go through a period where they can't make money because they're either addicted and unable to function regularly or are in prison. Because of this, their children don't have any money and need to drop out of school because they need to make it. And because they don't have an education, they probably can't make a lot of money and turn to the only place that seems familiar and a source of income: drugs. And because of that, the cycles continue. We as a country have failed those communities by not providing a way out for them. There are a variety of risk factors that are linked to prescription drug abuse, but most of those are because of poverty. In 2017, around 18 million people, 6% of the United States population, are over 12 years old, use prescription drugs outside of their designated medical use. Misuse of prescription drugs is highest among young adults between ages 18 to 25, with about 15% reporting non-medical use in the past year. And among youths aged 12 to 17, 4.9% reported past year non-medical use of prescription medications. That is the group we decided to focus on in our presentation.
In this study, there were several determinants of health we decided to focus on. By utilizing the socio-ecological framework model, we first looked at the individual level. At this stage, we are focusing on a person's inner feelings when faced with addiction, and on the interpersonal level, it can become a huge economic burden since many drugs aren't easily accessible without contacting ill-intentioned or sketchy people through the black market. On the community level, many people who struggle with substance abuse disorders find their relationships with others to become very strained, with shorter and aggressive interactions. Lastly, on the macro system level, large companies nicknamed part of Big Pharma profit most off people's addictions. And this is because of health insurance being too expensive and not able to cover the cost of many medications, making it inaccessible for many, which is a huge factor that contributes to people who need to find alternatives for pain relief and certain medications. And in this stage, we also touch upon ethical issues such as removing children from drug-abused homes. Our official research question for this study poses the question of whether or not the mental health of younger children ages 11 through 17 differs from those with parents that have an addiction severity index score from 0 to 2 or 7 to 9. The diagram below is an example of how the addiction severity index looks in another study. Our null hypothesis is that there is no difference in the mental health of children ages 11 through 17 who have parents with an addiction severity index score of 0 to 2 and children ages 11 through 17 who have parents with an addiction severity index score of 7 through 9. Our alternative hypothesis is that there are higher levels of mental illness in children ages 11 through 17 than those who have parents with an addiction severity index score of 7 through 9 than children ages 11 through 17 with parents who have an addiction severity index score of 0 through 2. Like I had previously mentioned, we decided to utilize Bronfenbrenner's socio-ecological framework for our study since it worked best with our research question. Our stakeholders for this specific study were children ages 11 through 17 in the United States, although anyone could be affected by addiction or a substance abuse disorder.
There are a lot of variables that we need to be aware of. in our study. The first one, our dependent variable in our study, is mental health. Our measurement for mental health will be categorical ordinal because we'll be ranking the child's mental health into the categories of mild, moderate, moderately severe, severe, or none. These categories will be a result of using the severity measure for depression for ages 11 through 17, hence why we have the population of children ages 11 through 17. In a few slides, I'll explain more about the severity measure for depression for ages 11 through 17 and why we decided to use that for our study. The independent variable in our study is the Parents Addiction Severity Index score. The Addiction Severity Index score gives addiction scores on a scale to 0 to 9, where 9 is severe addiction. So since we chose to use the Addiction Severity Index score, the parents' addiction score is also a categorical ordinal variable. In addition to our dependent and independent variables, it's also important to consider the moderating, mediating, and confounding variables that may be present in our study. One potential mediating variable could be seen in our study is the stress of the child. Having a parent who is an addict puts a lot of pressure on kids and can lead to them experiencing high levels of stress. Kids with consistently high levels of stress are also more likely to experience mental health issues such as depression and anxiety. A moderating variable that could occur in our study would be the amount of social support the kids have. If the kids have other supportive family members, friends, teachers, or anyone they can turn to, they're more likely to have a safe outlet for their emotions and are less likely to experience mental illness. However, if a child has a parent who is an addict and they don't have any source of emotional support, they're more likely to internalize their feelings and experience more mental health issues. Lastly, a confounding variable in the study would be socioeconomic status. There's an association between lower socioeconomic status and higher rates of substance abuse. In addition to that, there's also potentially a causal link to those who have lower socioeconomic status and higher rates of depression and mental illness due to stress and challenges that come with being in a lower socioeconomic status. One construct that we'll be measuring in our study is mental health. To study mental health, we'll be specifically studying depression and anxiety. And in order to operationalize depression, we'll be using the severity measure for depression for ages 11 through 17. This is a short survey that uses variables of sadness, lack of interest, trouble sleeping, poor appetite, fatigue, self-esteem, trouble concentrating, slow speech, and suicidal thoughts to determine the level of depression. Each one of these variables are measured by ranking how often the participant has experienced those feelings in the past several days, with like 0 being none at all, 1 being several days, 2 more than half of the days, and 3 nearly every day. This process of assigning these variables to different categories is an example of categorical ordinal level of measurement. And then once all of the variables are measured, the scores are added together, and that determines like the level of depression. 0 to 4 is no depression, 5 to 9 is mild, 10 to 14 is moderate, 15 to 19 is moderately severe, and then 20 to 27 is severe depression. So
when looking at the severity measure for depression for ages 11 to 17 as a way to measure depression, it can be seen how it is a reliable method to determine depression as the scale never changes, and it is always the person who is being looked at filling out how they feel. The scale of 1 is several days, scale of 2 is more than half the days, and 3 is nearly every day. Doesn't change for any particular participant or moment in time, keeping the results consistent for anyone who takes it. Additionally, since the only person who can answer the questions and determine their internal thoughts and feelings would happen to be the person being looked at, the results come right from the source. When looking at the study design, we've determined that we will use the prospective cohort as the study design because our study follows the participants over time. During the study, we are looking at children who have parents with or without high addiction scores and tracking their mental health over a span of time. Above, you can see a visual of what a cohort study may look like. For our sample, we plan on making the sample size about 200 to 300 participants from all demographics, but specifically ages 11 to 17, as that is what the depression study focuses on. The potential locations for recruitment of study participants would include advertising the study to schools, workplaces, and hospitals. Schools would be a useful location because both students in the correct age bracket and parents would be walking through the halls and could see the flyer and decide to participate, especially if there is someone who has or is a parent that has struggled with drug addiction. Additionally, the same applies for workplaces and hospitals, as people can volunteer to participate knowing that they fit certain criteria that is under study. The quantitative data collection methods we will be using during this study are surveys such as the severity measure for depression for ages 11 to 17 and questionnaires that allow us to determine which children have and do not have parents that have struggled with addiction. The sources of data collection we will use in the study are records and surveys. Records would allow us to find out specific people who may have struggled with addiction and have children, thus enabling us to reach out to them and be involved in the study. Surveys, like mentioned above, would be able to determine the depression of children.
There are also many ethical considerations we need to keep in mind when we're doing this study. The first that we should be aware of is confidentiality. Since this intervention deals with drug addiction, it's important that any information shared is kept confidential. The information participants are sharing is very personal, so it's vital that a person is willing to share their personal information and they know that they're protected from their information being shared with anyone besides those they intended it to be shared with. Next is just voluntary consent. Like, we want everyone in our study to choose to be there. We can try to incentivize them to come, but we're not going to force them to be involved. Also, it's important that participants know that they can leave the study at any time with no punishment to them. It's possible that some of the survey questions may be hard to answer or may be triggering to them. So if they feel the need to leave or they become uncomfortable, they need to be willing to do so. They can't be forced to stay. There should be no punishment for leaving as well. And then lastly, it's important that the study provides societal value. We believe this study does provide societal value because the more we learn about the costs and the damages of having a parent who struggles with addiction, the more that we can advocate for children's mental health who may be in that situation. And then in addition to ethical considerations, there are also several cross-cultural considerations that need to be addressed in the study. First, we need to make sure that the locations in which we recruit people for the study are diverse so that we can have people from many different backgrounds in our study. To do this, we'll make sure to market our study at all of the locations that Dakota mentioned before, such as schools, hospitals, and workplaces. And once we have a diverse participant sample, it's important that our research team is reflective of that diversity so that participants always have someone they view as similar to them and can feel comfortable sharing their personal information with. So we need to make sure that our research team is diverse as well and reflects the diversity we want to have in our sample. We'll make sure to test the study to make sure that it works for all different cultural backgrounds. While testing the study, we'll be able to make sure that the study is friendly to participants who maybe speak a different language or may not be aware of the meanings of different things. And also just make sure that the way we phrase questions aren't triggering to a certain culture or anything like that. So just testing the study to make sure that it works for everyone.
To summarize the information presented in the last few slides about quantitative research, we are going to be utilizing surveys as our quantitative data collection method, such as the severity measure for depression for ages 11 through 17, as Mackenzie and Dakota have both previously touched upon. Surveys work best for us in this research position because we are directly contacting our sample of participants through online or in-person surveys that participants will have easy access to. We will be using a sample size of about 200 to 300 participants aged 11 through 17 in the United States, with the target locations of schools, hospitals, and workplaces. Lastly, there should always be some sort of ethical set of guidelines in any study in order to emphasize the importance of not harming the participants. Although the questions in our surveys about mental health may be triggering for some, it is extremely important to remember that participants are free to leave and stop participating at any time and are not bound by any contract to stay again, so that they don't have to stay against their wishes. Alrighty, and the last slide here is just a combination of all of these sources that we all used, properly cited. And if you have any other further questions about our study or anything about this topic, please let us know. Thank you so much for watching.